You are asked to see a 38-year-old female presenting with epigastric pain. Tell me, how will you approach this patient?
Great. My approach will be very systematic. First, I'm going to take a detailed history followed by a thorough physical examination. Based on what I find, I'll formulate a differential diagnosis, order the necessary investigations to narrow it down, and finally propose a comprehensive management plan.
So getting into the history, what we know is this is a 38-year-old female who's had epigastric pain for about a month now. She describes it as a dull, aching, and continuous pain. It's important to note that the pain hasn't radiated or shifted, and there are no associated symptoms like nausea, heartburn, or any weight loss.
Now, here's a really critical piece of her history. She has been taking oral contraceptive pills for the past 5 years. This is a huge clue that's going to point us in a very specific direction. Moving on to the physical examination. The patient looks comfortable, her vitals are all within normal limits, she's not jaundiced or pale, and there are no signs or stigmata of chronic liver disease. Her abdomen is soft and not distended, but on palpation, I feel a well-defined, about 5 by 5 centimeter mass in the epigastric area. It's mildly tender, and importantly, it's non-pulsatile. Okay, based on the history and your examination findings, what is your differential diagnosis? My differential is broad, so I'd like to organize it into categories. First, the 9 liver lesions are high on my list, including hepatic adenoma, hemangioma, FNH, or even a simple cyst. We always have to consider malignant possibilities like hepatocellular carcinoma or metastases. And then there are other potential causes to keep in mind, like a hydatidic cyst, a liver abscess, or maybe a mass coming from the stomach or biliary tree. And from that list, what is your leading provisional diagnosis?
My provisional diagnosis is hepatic adenoma. It just fits perfectly. We have a young female, a solid liver lesion, and that crucial history of long-term oral contraceptive use. It's a classic presentation.
Good. So what investigations will you order to confirm your diagnosis?
To confirm, I'd start with some baseline lab work, the CBC, liver function tests, and a coagulation profile. I'd also check amylase and lipase to rule out the pancreas. Then, for imaging, my first step would be an abdominal ultrasound, which is a great initial test. But for a definitive diagnosis, the gold standard here is going to be a triphasic CT scan of the abdomen. So the triphasic CT is really where we expect to see the telltale signs. For hepatic adenoma, we're looking for a solitary, well-encapsulated lesion that shows this really specific pattern. It enhances brightly and homogeneously in the arterial phase, and then it basically washes out, becoming isodense with the surrounding liver in the later portal and delayed phases. That pattern is what really clinches it. The diagnosis of hepatic adenoma is confirmed. How would you manage it? The management follows a pretty clear algorithm. For a small lesion, less than 5 centimeters, in an asymptomatic patient, the first step is to stop the OCPs and then just observe. However, if the patient is symptomatic or if the lesion is larger than 5 centimeters, the treatment is surgical resection. And, in the worst case scenario of a rupture, a stable patient gets embolization followed by a planned resection, whereas an unstable patient needs an emergency laparotomy right away.
So applying that algorithm to our specific patient, she's symptomatic, and her mass is right at that 5 centimeter threshold. So for her, the definitive management is surgical resection, aiming for clear negative margins.
And what are the key elements of her post-operative tear?
Post-operatively, this patient needs close monitoring, so she'd be admitted to a high-dependency or intensive care unit. The priorities are getting her moving early with DVT prophylaxis, starting enteral nutrition as soon as it's safe, and ensuring she has good pain control. Of course, we'll be monitoring her blood work daily, CBC, LFTs, electrolytes, and keeping a very close eye on the output from any surgical drains for signs of blood or a bile leak.
All right, let's switch gears and really hammer home the high-yield exam pearls. These are the key takeaways you absolutely have to know for hepatic adenoma. If you remember just one thing, let it be this. In a young female with a solid liver lesion, the history of OCP use is the single most important clue. It's the classic exam trigger that should immediately make you think of hepatic adenoma. Now, let's talk about the magic number, 5 centimeters. This isn't just an arbitrary measurement. It's the critical decision-making threshold that will guide your entire management plan. And here's why that number is so important. Once an adenoma gets bigger than 5 centimeters, the risk of 2 major complications, spontaneous hemorrhage and malignant transformation, goes up significantly. That's why we recommend resection for these larger lesions, even if the patient feels completely fine.
Finally, you need to know what to do in a crisis. If an adenoma ruptures, your action plan is dictated by one question: is the patient hemodynamically stable? If they are stable, you can control the bleeding with angiographic embolization and plan for surgery later. But if they're unstable, it's a true surgical emergency. Straight to the OR for a laparotomy, Pringle's maneuver, and liver packing. Knowing this distinction can be a pass-fail point.
So, to leave you with one final thought, you've mastered hepatic adenoma. But how would you tell it apart from its great mimicker, focal nodular hyperplasia, or FNH? What is the key differentiating feature you'd look for on that triphasic CT? That's the next level of understanding.